Well, hello, everybody, and welcome to today's show. My very special guest, once again, is Howard Schubiner from Michigan. It's great to see you, Howard.
Yes, thanks for having me, Wayne.
Okay, so since we talked a little while ago, the big study has come out, the Boulder, Colorado back pain study, a randomized controlled study that Howard was one of the co-authors, main authors. And today we're going to talk all about it because this study is it's basically at a pivotal point in chronic pain because we've been waiting for a long time to get a really good study to come out to show that we can help people get to pain-free, and yeah, it's just great. I've been using the information from the study in my practice in the last couple of months because it came out in September 29th in JAMA Psychiatry. So anybody listening today, you can Google JAMA Psychiatry and look up Gordon or Schubiner as an author and you'll get the study. You can have a read. So Howard, let's talk about this. Let's go back. How long was it in the process of getting to this point of publication? How many years?
That's a great question. I think it's about 5 years. I think
Wow.
About 5 years, yeah.
Wow. And what were some of the reasons why it took so long?
Research is hard, Wayne. Research is hard. It's hard. First, you have to have the setting. Where are you going to do the study? Where are you going to get the patients? Who's going to do the work? Then you need the money. Who's going to pay for it? And then you need to assemble the whole team and get the whole program together. And then you actually have to do it. So what happened with this study, it was really an amazing process. And the researcher, a neuroscientist who was at University of Colorado in Boulder, is Tor Wager. And Tor, top neuroscientist for pain in the world, one of the top two. He's well known for his functional MRI work. He's published all over. He's published in the New England Journals and speaks all over the world. And it was his lab. And he runs this, got high level research going, level fMRI machines. And I met Tor at conference over the years. And I was every time I'd see him, I'd bug him and I'd say, Tor, we have to do a clinical trial. Because a lot of his research was experimental research with experimental pain, seeing what happens in the brain with experimental pain, anticipation pain, placebo effects, things like that. So I had a phone meeting with him coming up, and I was talking to Alan Gordon about it, and Alan said, well, how much would it cost for us to find out from Tor what it would cost for us to run a back fMRI trial. And so I was on the phone with Tor, and he brought on his one of his PhD students, Yoni Ashar, on the call, and I asked him the question, and he said, we're just starting a back pain right now, and then the next few months we're going to be doing a study where we can people who get a placebo back injection versus a treatment as usual group. And so following Alan's question, I said, well, how much would it take for us to add a third arm to the study, arm where we treat the patients, back pain patients, our mind-body approach? And he said around 40 or 50,000. And I said, well, let me get back to you. And I called Alan. I said, we need 40 or 50,000. And Alan said, we'll raise twice that, no problem. So Alan and I created indie, I guess, go campaign. People from all around the world contributed to it. People cared about mind-body medicine, and people who knew our work. And we raised I think about $80 total. And Tor was, followed through. He says, yeah, well, you can do it. And Yoni Ashar was the grad student running the study, and Yoni came to work with us following that and learn about all of our techniques and what we're doing. And the study got off the ground. So, and it took 2 years, roughly 2 years, just to do the study.
Howard, just before we dive into this, can you switch your mic again back to your Mac, because there's feedback. Okay, so here we go. So everybody listening, this is an amazing study that was just published. Okay, there's probably the first of its kind. You know, it took world leader Tor, Wagner, to be chatting with this guy here, who's again a world leader in the world of mind body medicine, because he set up the whole mind body medicine in Michigan. I think it was Michigan. And he counsels people. I was even talking to one of your students in the UK, and we've been talking about this a little bit. I'm heading back to the UK in a couple of weeks. And, so this movement that's going around medicine, where we need to realize that the mind and the body are kind of working as a team. It's kind of crazy to say that as, professionals talking about this, but very few people really understand that the way clinical medicine has been taught for hundreds of years is this separatist or dualistic theory from Descartes from France, and that's where it all happened 400 years ago. But we're still in this day and age of just looking at the brain or the back or whatever we're looking at, and it's not connected to the mind. And we all know that if you've got a bad day, you're emotionally, mentally, then it's going to affect your health. But yet we haven't put that into clinical practice. So what Howard's done and his team here have done is literally given us something to hang our hat on, so we can actually change the direction of medicine and allow people like you listening to this to go pain-free, because that's what they found. Okay, so Howard, let's go back to this. So you spent a bit of time, you spent years, literally a couple of years. So what actually happened in the study? You were involved with the first interaction. So what happened then? And let's move on to the next line with Yoni and Alan in LA.
Well, we recruited in Boulder, Colorado, which is a particular population. It's a very fit population. The average age was 41, so it was a relatively young population. But that was the average age, 41. So there are people in their 20s and people in their 60s.
Yeah.
And the average duration of back pain was 10 years.
Wow.
So people had back pain for quite a long time. That was the average duration of back pain.
Wow.
And they had to have a certain amount of back pain. It had to be at least a 4 out of 10 average, at least that, on a 10-point Likert pain scale. And we excluded people who had leg pain more than back pain, we would exclude people who were more likely to have disc problems causing pain in the leg as opposed to back pain. We excluded people who had histories of cancer. We excluded people who had autoimmune disease. And then they had to have an fMRI of their brain.
Yeah.
So they all had fMRIs of their brain prior to the study, and they had to have pain that got worse when we blew up a pillow under their back in the fMRI machine. Blew up, I mean inflated, a pillow under their back. So they had pain that increased in their back when their back was stressed by this inflatable pillow. So
that was a brilliant idea. Like, who thought up that? Who would have thought up of blowing a pillow up in an MRI machine?
Yeah, And so when they had pressure on their back, their pain increased.
Yeah.
Which you would think would mean that there's something, maybe there's something wrong with their back.
Yeah.
The pressure causes more pain. So then the people were randomized into 3 groups. One group got a control group, treatment as usual. A second group got an injection in their back, and this was a placebo injection. They were also told it was a placebo injection, so it's called an open label placebo. That's been shown to have positive effects on people with chronic pain, at least to some degree. And then they had the third arm was randomized to our group, the Mind Body Medicine Treatment Group, which was 50 people. Of the 50 people, I evaluated 45 of them. And I got a license to practice medicine in Colorado in order to do the study. And I went over their whole history. I spent about an hour with them, virtually, not in person. I went over their MRIs. I went over all their history. I went over all their life events. And I told them about the brain and pain. And I concluded that 43 out of the 45 had literally nothing wrong with their back. They did not have a structural problem. That's 95%. Now that's an amazing number in and of itself.
Right, so 45, and you told me before we got on 43 you thought were right, there's brain recircuit problems. So it's a program that's not working right in the brain. That's what the main reason is. And the two, tell us about the other two, though. You thought they were structural, and what happened?
I thought the other two I thought might have been structural. One person had a history of a disc problem that was causing pain in the leg, and the other person had a very complex history with several spinal surgeries and a lot of spinal deformity. So I wasn't sure, and I didn't want to. I wanted to be conservative and not say that everything is completely mind-body if I wasn't sure. I was sure in the 43. The two who ended up being in the kind of combined category, one of them did well and her pain went away. So turned out she didn't, I don't think she actually had structural pain. The other one did so-so.
Okay, so you had 45, and the other groups, they had about 50 or 45 in each group too?
50 in each group, but of the 50 people randomized to our group, only 44 got the treatment.
Right.
6 people dropped out.
Okay, so that's quite pretty good numbers then for studies, is that?
Yeah. I mean, it's not a huge study, but it's a big study if you're considering getting fMRIs of everybody pre and post.
That's right. So they were enrolled, you saw them, you had a chat with them, and then what was the intervention, over the next couple of weeks? I think it was over 4 weeks, was it not?
Yeah, for the next 4 weeks, they had 2 visits, 2 individual visits per week. So a total of 8 sessions with either Alan Gordon or Christy Weepy. These were the 2 therapists who did the interventions. And the interventions were based on the model of pain reprocessing therapy, which is the model that helps to interrupt the vicious cycle of pain. And the vicious cycle of pain primarily consists of pain, which leads to fear of the pain, focus on the pain, worry about the pain, being frustrated by the pain, trying to figure it out endlessly and trying to fix the pain. All these things actually reinforce neural circuits in the brain that make pain worse. So most people with chronic back pain and many chronic pains actually get worse over time because of this vicious cycle.
Okay, so the vicious cycle is going on, and I can vouch, after 20 years of being a GP, that giving pills and doing more scans and referring to A, B, C, D, E, in the regular practice just actually makes it worse from a pain programming perspective, right?
Right.
This is going on all the time, and as I say to patients as well, like pain is one of the biggest stressors, and that programs you for more pain because you learn more about pain, and pain, programs the limbic system even more. So without knowing it, we're just getting worse, and that's kind of the story of pain, isn't it? Okay, so you're identifying this, you're educating them, but what are the patients actually doing once they leave these 1 hour or double meetings every week? What are they actually doing day to day to kind of change this?
Well, in the therapy sessions, they're getting taught, and not only taught, not only told, but shown experientially that their pain is due to a neural circuit in the brain and not due to a structural problem. So they'll be given exercises where they're calming their brain, and then they're stepping back and watching what their brain does, watching what happens to the pain. This is called somatic tracking or mindful awareness. And when they can calm their brain and step back and lessen fear of the pain will start to shift or move or get better or get worse. And they can see that happening. They're not moving, they're not doing anything. So then they begin to realize, oh, my brain is making the pain better. It's making it worse. It's making it move around. We're giving them exercises where they, if they have pain with standing up, for example, we'll have them calm their brain and tell themselves they're okay, and then fearlessly stand up for 5 seconds or 10 seconds and see what happens. And then sit down and then stand up again and then stand up again. And each time they're seeing a little shift, they're seeing some difference. And so the pain may have been there the first time, but then the second time it wasn't as bad. And the third time they didn't have pain when they stood up, and they're going like, what's happening? That's amazing. There's a shift. And then they go out into the world, and then they start walking or bending or twisting or doing the things that had aggravated the pain, but they're doing them without fear. They're smiling when they do them. They're laughing when they do it. They're telling themselves they're okay. They're reminding themselves they're fine. And this is all turning off those neural circuits of pain in the brain.
Amazing. I hope everybody gets this who is listening to this. It's absolutely revolutionary.
It's an amazing process to watch and be part of. And we see it working every day. And I'm teaching people to do this, teaching other doctors, teaching physical therapists, teaching psychologists, teaching social workers, teaching acupuncturists, chiropractors, massage therapists to do this, because it's really not that hard. And you can see the clues all the time when someone says, I went away on vacation and the pain went away for 2 days. Well, that's not a structural problem. When someone says the pain is sometimes on the right side of the back and then it goes to the left side of the back, that's not a structural problem. So, you know, the clues are right there to be seen once we know what to look for.
Okay, so you said, or what Alan said in his book that describes his book, that it was pains of less than 4
Greater
when
than
you practice that. Was actually done, or was it higher pains as well?
Well, to be in the study, they had to have pain 4 out of 10 or higher.
Right. Okay.
Yeah. And so, you know, there's different ways to think about it, but the key point is not how much pain someone's having. The key point is how much fear they have of it.
Yeah.
If they can lower their fear and their focus on it, if they can learn to understand that they're not damaged, if they can begin to, like I was working with a lady today who was having pain, and I was talking about how you can change the brain by pairing positive influences with pain as opposed to negative. So the neurons, as you know, neurons that fire together wire together. And so when people are having pain and then they bend and twist and it gets worse, and they bend and twist and it gets worse, they're learning more and more pain over time. And she was having this numbness and tingling sensation in her hands and feet. And I asked her to think of something really positive. And she thought of her favorite kind of ice cream, you know, cookie dough ice cream. And so she's imagining eating cookie dough ice cream. And then she's calming her brain and breathing slowly and observing the sensations in her hand as she's thinking about cookie dough ice cream. And the sensations in her hand got better.
Yes.
As she changed her mood, and as she changed her affect, and as she changed her conceptualization of what was going on, and the brain started turning off her pain. So now she knows it's not her hands, it's not her feet, it's her brain, because she has the power to change it by changing her brain.
Wonderful. And what I've also learned from yourselves is this 5 senses can be used, you know, as a distraction or enjoyment. To be a better word is enjoyment, say the sights outside or the taste of the ice cream, not maybe just the visualizing, but actual the taste of it, the smell of the cooking, or, you know, the touch of the water on your back, or a bath, or, you know, so you've got 5 basic senses, and just tapping into a micro moment of mindfulness and just being present there. So was that part of the advice in these therapy sessions?
Yeah, that's part of it. And part of it is laughter and humor and developing a positive mood and a positive affect.
Right.
You know, when a child, you catch a child with their hand in the cookie jar, you can get upset, or you can just smile and say, I see you. And so when you catch your brain making pain, generating pain, you can smile and say, I see you. And then you've taken away the power that the pain has over you.
Yeah, it's so powerful. It's so important. Right, so we've talked about a couple of components within the therapy session. Was there anything else that Alan and Christine were focusing on?
That was the most important parts of it. They wanted people to then get back to their lives. They wanted people to engage in their life in ways that were positive and meaningful and purposeful, and seeing people and doing things that they might have restricted due to pain, because they didn't want them to make their pain controlling them. They wanted to live their life, because when you live your life and you do things in your life, whether you have pain or not, because you're not afraid of it anymore, you know it can't hurt you, then you're training your brain that the pain isn't dangerous.
Okay, so that's what the therapy and intervention was, twice a week for 4 weeks, 8 sessions with you at the beginning. And then what were the results?
We found that of the 44 people that we treated, 33 were pain-free in 1 month. That's 75% of the 44. Statistically, we think of it as 33 out of the 50, because 50 were actually enrolled, even though 6 dropped out. Nevertheless, when you do the statistics, it's called intention to treat analysis, as you know, 33 out of the 50, which was 66% or so, were pain-free in 1 month. So this is a very, incredibly positive result compared to most pain studies. In the other 2 groups, there were roughly between 10 and 20% who became pain-free. So it's a huge difference between the groups.
I think one thing I've learned from you today, and it's important because, in Alan's book, The Way Out, which we'll mention at the end, and also my reading of the study, was I took that the pain was less than 4, but it wasn't. It was average, at least 4, not less than 4. It should have came down to 4, and therefore maybe that's when the focus is really on that tracking, following the body sensations. Because if it's 6 or 7 or 8 or 9 or 10, it's very difficult to kind of sit down and do that work, right?
Yeah, sure. Yeah, that's true. And so you're trying to catch people at times. You're trying to help them lower their pain at least to a moderate level before you can watch it and pay attention to it with less fear. But I found that there's a lot of techniques we can use to help people lower their pain. And like I say, one of the things that I like to use is have people imagine doing movement. Like if their neck is painful with turning their head, I have them imagine turning their head. And when the pain increases, when they imagine turning their head, that blows their mind, because now it's not, they can see like it's not my neck. Well, I didn't do anything. I was just thinking differently. So there's just a lot of techniques that we found over the years that can really help to show people, not just tell them, but demonstrate to them that it's actually their brain. And then they can really go and make great progress in lowering their fear.
So are these results applicable to everybody with, there is recircuit brain pain of any level?
Yeah, well, we think so. I mean, you can't say that when you do a study and it shows efficacy in back pain, you can't necessarily assume that it will work for migraine or tension headache or abdominal pain or et cetera. But we've been doing this for 20 years. Dr. Sarna was doing it for 50 years. And, we know that it works equally well in these other pain syndromes, as long as we've ruled out a structural problem.
So can you just name a few of the different symptoms that are not specifically pain, but people have them all the time, and we know it's a brain circuitry problem?
Yeah. So in addition to the common ones that I mentioned just a minute ago, insomnia, chronic fatigue, anxiety, depression, diarrhea, constipation, ringing in the ears, tingling, numbness, burning of the hands and feet. These are other common symptoms that are commonly, again, you can't say always, everyone needs a good evaluation, everyone needs tested. Just because ringing in the ear is often a mind-body type problem doesn't mean it always is. It certainly can be due to a structural problem that needs to be, ruled out.
Wow, so you just went around the whole body there and just said diseases that, specialists see all the time, but yet you're finding results in your practice of these symptoms going away.
Right.
Truly, truly amazing. Well, the mind and the body must be a unit then.
Yeah, it's the power of the mind.
Yeah, I know.
Body is really unknown and untapped. The power of the mind And, you know, we've learned, I think I mentioned last time I was on your program, that our brain actually generates everything that we experience. When you touch a hot stove, it's not your finger causing pain, it's the brain.
Yeah.
And when we see, it's not our eyes causing vision, it's our brain causing vision.
Yeah.
And that's the amazing thing, the power of the brain.
Right. Right. Okay. Any tips for our audience to maybe sources or where to go to read more about this so they can learn a bit more?
Yeah, for sure. We have a professional organization called the Psychophysiologic Disorders Association, ppdassociation.org. There's a peer-run website called tmswiki.org, and both of those are nonprofit and all free information on trainings, on courses, on books, on websites, on podcasts. And then there's a whole host of books that are out there. Dr. Sarno's wrote 4 books. His books still selling. They're amazing. I've written 3 books. One of those with Dr. Alan Abbas. That's for professionals. The PPDA has a textbook for professionals. And then you mentioned Alan Gordon's book, The Way Out, is excellent. David Hanscom has a book. David Schechter has a book. David Clark has a book. Georgie Oldfield in the UK has a book. These are all excellent books on the same field.
Well, thank you for that. That's great. Any final comments?
I think it's just to really try to be open. You know, I think that's what we're all doing. We're trying to be open to the idea that the brain can actually cause a whole variety of symptoms. And when it's the brain, it's completely reversible. But we also have to be open to know that the body can be damaged sometimes, and we need to be careful and cautious and not assume that just because someone has back pain that it's due to their brain. We have to do the work to make sure that we know what we're talking about. And we need to be kind and caring to people. When people are told that the pain is due to their brain, they get the impression it's all in their head, that they're faking it, that they're crazy, that it's their fault, that it's imaginary pain. None of that is true. The people who have pain due to their brain are the people who need the most compassion because they are suffering and the pain is real. And oftentimes they've been through a lot of emotional stressors in their life that have contributed to making the pain that way. So if they don't deserve compassion, I don't know who does.
Sure. I completely agree. Well, thank you, Howard. It's been a pleasure to see you again and talk about this big study that's getting me really excited. My practice has changed a lot in the last couple of months. And, you know, in my first or second visit, this is what I talk about all the time. So, and it works. People are coming back, you know, with amazing outcomes. So thank you for the tenacity to finish this thing and get it out there and for all your work that you do.
Thanks, Wayne. It's always a pleasure. I hope to see you soon.
Okay. Thank you.
Yeah. Bye-bye.